Hello everyone, this is Dr. Chandana Vishwanatham. Your MRCP well-wisher for your MRCP. I would in this video I want to talk about respiratory system for MRCP part 1 and part 2. If you have not seen my previous video on COPD, please go back and see that video and come back to see this video because this is an addition to what I have already discussed. In my previous video, I have talked about COPD, the important aspects such as the diagnosing COPD and management of COPD. And in this video, I will be taking the COPD topic to another level where I will be discussing some important topics which are high yield for MCQs. Repeatedly asked questions are there from these topics. So I wanted to make a separate video on these topics. So let's go into these important topics. First one is roflumilast. This is a drug that is used in COPD patients who are on maximal therapy, that is LABA, LAMA, and ICS. If you remember the flowchart that I have displayed in the previous video for management of COPD, the last option was LABA, LAMA, and ICS. Even if the patient is on this therapy and the patient is having uncontrolled COPD, then you can consider this drug, which is roflumilast, which is a phosphodiesterase inhibitor, which is recommended by NICE. But the patients have to meet some criteria before we start this drug. There are two different criteria. There are two things that need to be there in one patient. It is not any one of the two. It is the two things that need to be there in one patient. Only then you can start roflumilast, which is a last option. The first one is severe disease defined as forced FEV1 after bronchodilator is less than 50% of predicted normal, and this should be there in a patient who is using LABA, LAMA, and ICS. So this is the treatment the patient is already on, and in spite of this, the FEV1 is less than 50%. So in that case, you can consider roflumilast, and the patient should also have 2 or more exacerbations in the previous 12 months, despite triple inhaled therapy with LAMA, LABA, and ICS. So these are the two indications of roflumilast. These both need to be there in the patient to start this drug. So repeatedly MCQ have been asked on this topic, where the patient will be uncontrolled COPD who is on this triple inhaled therapy, and they will be asking you for the next best appropriate line of management. Mainly in the MRCP part 2, these kind of MCQs can come up. So don't forget about this roflumilast. And coming to another important topic, which is smoking cessation, and this includes NRT, which is nicotine replacement therapy, and varenicline and bupropion. So NICE states that clinicians do not have to favor one medication over the other. All the three are equally good options. But usually the patients will be started on nicotine replacement therapy, which is commonly used. And these should be prescribed along with the prescription. They should be told about a target date that they need to stop on a particular date or before. This is target stop date that you have to explain to the patient, and the dosage, the prescription should be sufficient to last only until 2 weeks after the target stop date. So if you have started the patient on this smoking cessation therapy and you give a target stop date after 2 weeks, then you have to give your prescription for 4 weeks. So normally this will be after 2 weeks of NRT therapy and 3 to 4 weeks of varenicline or bupropion. Usually it takes time for these medications to act compared to nicotine replacement therapy. So this therapy is longer compared to NRT, and further prescription should be given only after considering if the patient is committed to continue the quit attempt. So further prescription should only be given when the patient have demonstrated that their quit attempt is continuing. So after this initial therapy, you have to call back the patient to come to the OPD, and you have to see if they are committed to this smoking cessation. Only then you have to consider giving further prescriptions of these drugs. And if unsuccessfully the patient is unsuccessful in smoking cessation, even on this treatment regimes, you have to do not offer a repeat prescription within 6 months unless specialized circumstances have intervened. So we have to wait for 6 months, and only after that you can again prescribe these medications. So, and you don't have to you shouldn't offer these medication in combination. So you should not NRT with bupropion, something like that. You shouldn't offer the patient such therapies. You have to give it separately. You either give this, or you either give bupropion. So it is like that. Coming to nicotine replacement therapy, the first one, the adverse effects are nausea, vomiting, headache, and flu-like symptoms. And these are nicotine replacement therapies are available in different forms, like gums, inhaler, patches. Nicotine patches are available, which are very commonly used. Lozenges and nasal spray are also available. These are different forms of nicotine replacement therapy, and based on the patient's preference and the convenience of the physician, you can offer different forms of nicotine replacement therapy. The next drug is varenicline, a nicotine receptor partial agonist, and it should be started 1 week before the patient's target stop date. And after the stop date, you have to continue the drug for at least uh, 2 to 3 weeks. You have to continue the drug. So that is important. And the recommended course of after 2 to 3 weeks, you have to reassess the patient if you have to continue or if the patient is committed to the smoking cessation therapy. Only then you have to continue the treatment. And the total course of therapy is usually 12 weeks. But there should be regular monitoring, and the treatment is continued only if the patient is not smoking. So it has been shown in some studies that it's more effective than bupropion. And nausea is the most common adverse effect, and some other adverse effects include headache, insomnia, abnormal dreams, and should be used in caution with history of depression and self-harm, because this drug has in studies it has been shown that there is increased risk of suicidal behavior with this medication. So avoid using in patients with depression, self-harm. There can appear an MCQ on this, where the patient is having depression, then which drug to avoid. That would be varenicline, and it is also contraindicated in pregnancy and breastfeeding. So nicotine replacement therapy would be better if you used in pregnancy. And the other one is bupropion, which is an norepinephrine and dopamine reuptake inhibitor and nicotinic antagonist. It should be started 1 to 2 weeks before the patient's target stop date, and there is small risk of seizures. So it is contraindicated in epilepsy, pregnancy, and breastfeeding. So the question can be framed in such a way that the patient is having history of depression, and in past history they mentioned that the patient is having epilepsy, and they may mention the patient is pregnant or the patient is breastfeeding. So which is the appropriate smoking cessation therapy? In that case, you have to go ahead with the nicotine replacement therapy. So in that way, the question can be asked. And coming to pregnant women smoking cessation therapy, they have to all the pregnant women should be tested for smoking using carbon monoxide detectors, and all women who smoke or have stopped smoking within the last 2 weeks, or those with a carbon monoxide reading greater than 7 parts per billion or above, should be referred to NHS stop smoking services. So there can be an MCQ about which patient to refer to NHS stop smoking services in a pregnant female. So you have to remember these indications. And the interventions include the first line therapy is cognitive behavioral therapy. You shouldn't offer drug therapy as a first line therapy in pregnant women. You have to offer cognitive behavior therapy as a first line, and motivational interviewing, structured self-help, and NHS stop smoking services. But if these are unsuccessful in stopping the patient from smoking, then you can go for nicotine replacement therapy. Only if these interventions fail, then go to NRT. But varenicline and bupropion contraindicated in pregnancy, and these nicotine patches should be removed before going to bed if the patient is pregnant. And coming to oxygen therapy and non-invasive ventilation. So as I told you in the previous video also, the COPD patients are at a risk of hypercapnia. So when you give lots of oxygen therapy, that can decrease the respiratory drive of the patient and can cause hypercapnia, which is life-threatening. So aim to keep the saturations from 88 to 92 as a target saturations in COPD patients. After you achieve the target oxygen saturation, then you go ahead and do an ABG, where there are two things. That is, if the pH is less than 7.35, if the pH is greater than 7.35. So it means that the patient is, and in these two cases, the patient's PCO2 is greater than 6 kilopascals. So coming to this one, if the PCO2 is greater than 6 kilopascals, but the patient is able to maintain his pH above 7.35, that means the patient is not in acidosis. There is acidosis, but the patient is able to compensate it. Then you can continue oxygen and repeat ABG in 30 to 60 minutes. But if the patient is having PCO2 greater than 6 kilopascals, which is making the pH go down to less than 7.35, then you have to consider NIV. So moving on to the next slide, which is NIV in COPD, which is very, very important. There are questions that have been asked in which patients you will go for NIV, which is pH less than 7.35, and if the pH is less than 7.25, you go for invasive ventilation and mechanical ventilation. So patients of COPD are prone to develop type 2 respiratory failure. If this develops, non-invasive ventilation may be used. Typically in patients with respiratory acidosis that I told you, 7.25 to 7.35 pH, you go for an IV, and if the pH is less than 7.25, go for invasive ventilation. But in BTS guidelines, it is told that you can wait till the pH is less than 7.5, 7.25. I mean, till 7.25, you can wait without giving an IV. But in that case, the patient will be needing high degree of monitoring in high dependency unit. And in that way, we can use a lower threshold for intubation. But in coming to the MCQs, you always use this 7.25 to 7.35 pH for usage of non-invasive ventilation, and less than 7.25 for invasive ventilation. And whatever NIV we use in COPD is a bi-level positive airway pressure, which has two pressures which are set, which we need to set in the NIV settings. Don't confuse this with CPAP. CPAP is mainly used in patients with heart failure, but this BiPAP is used in patients with COPD. So the positive airway pressures, there are two positive airway pressures, one is expiratory and one is inspiratory positive airway pressure. There are many MCQs asked on these topics. I will be telling you in the next coming video in MCQs. So the expiratory positive airway pressure should be set 4 to 5 centimeters of H2O, whereas inspiratory positive airway pressure, the RCP advocates that 10 centimeters of H2O should be set, while the BTS suggests it is 12 to 15 centimeters of water. The pressures that need to be set when you are giving BiPAP to a COPD patient. So this has been asked in an MCQ previously. So what are the settings that you would advise for a patient with COPD has been asked. The next one is long-term oxygen therapy. This is very, very important because it has been asked in MCQs. So they will give a clinical scenario where the patient is having COPD and along with polycythemia, peripheral edema. Then they will give you some ABGs where the assessment is done. And if you want to go ahead with long-term oxygen therapy or not, will be the MCQ. So if you are planning to start the long-term oxygen therapy, the patient should at least be on oxygen for 15 hours a day, and you can also start the patient on a nocturnal NIV support along with long-term oxygen therapy, and assess the patient if any of the following are present. Consider this long-term oxygen therapy when the patient is having an FEV1 less than 30% of the predicted value, and when the patient is having very severe airflow obstruction, and for patients with FEV1 30 to 49% predicted, assessment should be considered for these patients also along with these patients. So, and when the patient is having cyanosis, polycythemia, peripheral edema, if the patient is having raised AVP, you need to examine the patient in detail. And oxygen saturations, if the saturations are less than or equal to 92% on room air, then if all these are present in this patient, any one of these features are present in a COPD patient, you can consider going ahead with assessment for long-term oxygen therapy. The assessment is done by taking two ABGs, or at least 3 weeks apart in a patient who is stable on optimal management. So the patient should be on optimal management, which is LABA, LAMA, and ICs, and the patient should be stable enough for the assessment. And you have to take 2 ABGs, which are 3 weeks apart. And these ABGs, if the value of PO2 is less than 7.3 kilopascals, you have to give long-term oxygen therapy. This is the major indication for long-term oxygen therapy. Or if the PO2 is 7.3 to 8, that is a little higher than the 7.3, so a little higher than this value, that is 7.3 to 8 kilopascals, then you can consider long-term oxygen therapy only when the patient has any one of these, which is secondary polycythemia, peripheral edema, or pulmonary hypertension. In the presence of these, you can consider giving long-term oxygen therapy. And to continue long-term oxygen therapy, the patient should not smoke. So do not offer LTOT to patients who continue to smoke despite being offered smoking cessation advice and treatment. This is a very important point. If the question has been mentioned that the patient is continuing to smoke, then you have to select the option with not offering LTOT, and we have to refer the patient to stop smoking services. And the next one is lung volume reduction surgery. So this is the trial that I wanted to discuss, the National Emphysema Treatment Trial, which is a prospective randomized multicentric trial that has compared the results of lung volume reduction surgery to medical therapy. So in this trial, they have come to the conclusion that the patients can be divided into 3 groups. The group 1 is upper lobe emphysema and low exercise capacity. So these patients showed improvement in both functional outcomes and survival after lung volume reduction surgery compared to the medical therapy. Whereas group 2 patients, patients with predominantly upper lobe emphysema and high exercise capacity, are included in this group. These patients have improved functional outcomes but no difference in survival outcomes compared to the medical therapy. So the group 3 patients are now on upper lobe emphysema and low exercise capacity. So this is important. This has been asked in an MCQ where the patient is considered for lung volume reduction surgery. They will give some options such as upper lobe emphysema with low exercise capacity, non-upper lobe emphysema with high exercise capacity. These something like this, and they have asked that which patient is unlikely to do well from lung volume reduction surgery and has a high risk of death. This includes patients with non-upper lobe emphysema and high exercise capacity. So these patients, this will be the option that you have to select. If the question is that lung volume reduction surgery is unlikely to do well and there is high risk of death, then you can select this option. And there is one more thing where there's FEV1 is less than 20% of predicted, or there is homogeneous distribution of emphysema, and DLCO is less than 20% predicted. So in these conditions, or in these when the patient is having these values of DLCO and FEV1, then also the patient is unlikely to do well with lung volume reduction surgery, because this means that there is no residual lung left for the patient to improve. So even if you resect a part of the lung, the patient will not improve in his symptoms. There will be no improvement in the patient. So my upcoming video will be on pleural effusion and MCQs on COPD. Please subscribe to my channel, like and share the videos if you find them useful. Thank you.